So we are stopping that circle of violence, of inflammation, new vessels, rupture, inflammation, because we stop the flow, the flow coming to those membranes, then the body will heal itself.
So you mean to say that the penetration into the dural blush area, the capillary network was less?
Most important part is that we need to get in contact with the referring doctors.
Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
So hello friends, today we are very happy, excited and honored to have a very renowned neuroradiologist from Spain, from the Hospital San Carlos, Madrid. And he's also coincidentally a good friend of mine. And we are very happy to welcome Dr. Manuel Moreu Gamathon. That's his whole name. But as you all know, we call him Manu for short, which coincidentally happens to be a very popular Indian name as well. So welcome, Manu.
Thank you very much. It's my honor to be here.
That's so good to have you here. So Manu, firstly, welcome to Mumbai, welcome to India. And we are happy that you made it here. And as I would like to tell everyone who's watching this podcast that Manu does a lot of work in the chronic subdural hematoma segment. So it was a nice opportunity for us to interrogate him and try and understand how he and his hospital introduced that practice into something so exciting. So before we move on to that, Manu, can you tell us a little bit about your hospital, your setup, and where you work at?
So I work in Hospital Clínico San Carlos. That's a traditional university hospital in Madrid. Mm-hmm. So we work really close to the university. We have close to 800 beds right now, with no pediatric patients. Mainly, we have pediatric service, but it's one of the smallest in Madrid. But so what we do right now is that we cover every specialty in my institution. And for neurointerventional procedures, we have one angiolab. It's a biplane, mm-hmm. and we have access to the vascular radiologist labs, mm-hmm. if we need it, that mm-hmm. are really door to door with us, mm-hmm. and we work really close with them. So that's our standard of practice right now. Mm-hmm. So we are in radiology department, mm-hmm. and one angiolab.
And how your team of neurointerventionists comprises of? So
we are 4 neurointerventional radiologists. Mm-hmm. One of us is working part-time between my hospital and Alfredo Casasco's hospital. Mm-hmm. So Santiago works with the two of us. Right. And then the other 2 neurointerventions will 100% of the time with us. And we have 2 fellows, right, who are about to finish their fellowship in July. All right. And then we will start with another 1 fellow.
Oh, nice. Okay. So now coming to the hot topic these days of chronic SDH, subdural hematomas. So can you tell me when did your hospital start adopting MMA embolization for chronic SDHs?
So we started, I think, back in 2019 or 2018. Mm-hmm. I was in Val d'Isère meeting, mm-hmm. And I heard a talk by Dr. Arthur from USA, and he was talking about this new approach of cSDH. So I came back to my hospital and we started to design an investigation registry, mm-hmm. so based in what we will be doing with our first patients. So we started that way. So I think it was October 19 or September 19, we started the registry. So then COVID came made everything a mess. So we started working with neurosurgery to try to treat only recurrent chronic subdural hematomas. And we get no patients in the first 6 months because they told us that there were no high risk for recurrence. So we started to think that maybe something was happening with those patients. So what we did, and thanks to Santiago, he's my partner in crimes, and we were talking, having a coffee in the cafeteria, and it was like, Santi, what's happening with these patients? Where are they? So what we did is we look for all non-contrast CTs in the emergency department for the last 6 months. So we rule out any other pathology, and we look only for cSDH, and we follow them into time. And we discovered that half of them or more, they were going to geriatric department. So we got in contact with these people because of that, and they told us, yes, of course, we have lots of patients with this condition. So we start working with them and start focusing on those patients who are not candidate to surgery or who are ruled out from surgery, and they go directly to the geriatric service, and we start to propose this treatment to those patients, and the results they have been really, really nice. So that's how we started with cSDH back in 2019.
Nice. So I think this story really started everywhere from 2017 after the pathophysiology of the vascularization of dura, etc. came up. So just because this podcast will go out to lots of young fellows or neurosurgeons as well who may not be very well versed with middle meningeal artery embolization for chronic subdural hematomas. Can you just briefly tell us about why MMA embolization works well in chronic SDHs?
Okay, so first of all, for those fellows, I think that they need to read Shapiro's paper. That's mandatory. And we also, one of my fellows, Angela, she wrote radiographics last year, I think, summarizing everything. And it's a really nice paper to read because it's, all the papers from radiographics, they are really well designed, and every draw, it's amazing. They are not as good as Shapiro's one, but so that's the first recommendation for everyone. And now, why MMA embolization? So back in 2017, as you said, we discovered that pathophysiology from chronic subdural was not that thing that we were told in medical school about the rupture of bridging veins. So we discovered that it's more an inflammatory process of the dura than anything else. And like every inflammatory process in the body, it heals with neovessels, and those neovessels are more prone to rupture. And because of that rupture, you have more damage, so more inflammation, more neovessels, more rupture. That's what actually happened in the chronic subdural hematoma. So by the end, what you are facing is that an increase in size dura with lots of membranes, with lots of vessels, and all those vessels receive blood from MMA.
True.
So the starting point, it was, okay, what if we close the MMA, maybe we will close those membranes, and we will allow the body to heal itself. So we are stopping that circle of violence of inflammation, neovessels, rupture, inflammation, because we stop the flow coming to those membranes. Then the body will heal itself. That was the main point of starting point of this theory. So that's what we started to do. We started to close the MMA. Our initial idea was to try to use liquid embolics to get through to those membranes. I think that right now I can tell you that we don't usually get to those membranes. So what we need is to close the vessels enoughly to allow those membranes to disappear and to allow the body to heal the dura itself.
Let's take a scenario of a geriatric patient coming in with an SDH, and he comes into your hospital and he either presents with, say, cognitive decline or a focal deficit or, consciousness levels going down. And say a CT is done. So how does this patient in your hospital go? He goes to neurosurgery, and do you all sit together and decide whether he's a candidate for surgery, burr hole, evacuation, or MMA embolization, or a combination? How does it work?
Okay, so it works this way. A patient comes to the emergency department with some symptoms normally. It gets a CT, so cSDH is diagnosed, and they call neurosurgery. Okay, so first neuro specialist that see that patient is the resident in neurosurgery, and with the neurosurgeon they decide if the patient is candidate to surgery or not. So if that patient needed an acute evacuation of the cSDH. So based on symptoms, clinical history of the patients, and the basal status of that patient, surgery is performed or not. If they do surgery, then that patient will go to the neurosurgery department, and the day after they will call us, tells us we have this patient, we believe it's a high risk of recurrence, so maybe embolization should be done. If we can do it that in-hospital admission, we do that. So maybe 2 or 3 days after that, we are able to perform an embolization. That's what I call the neurosurgery patients. But the ones where neurosurgery is ruled out, then those patients go directly to, normally in my hospital's geriatric service. Why? Because normally we are talking about, aged patients. So it's higher than 80 years old or 70 or something like that. So those patients go to geriatric. If the patient is younger than 75, I think they go to internal medicine. But most of them geriatric. So we receive a call the day after from geriatrics telling us, okay, we have these patients. Normally, if the patient goes to geriatric, it's because it's polymedicated, pluripathological patient. So that's why they go there. So we like that because, geriatric doctors, they love this kind of patient, of complex patients with lots of drugs involved, lots of pathologies. The treatment for those patients 3 years ago was put them under steroids. And you know that steroids is a great drug, but it changes everything in your body. So pluripathological, polymedicated patients under steroids, that was a mess. So there's these geriatric doctors, they work really well. So they study the patient and they ask the family about the previous state of the patient. And it's really nice what they do because we understand that cSDH has been evolving for the last month at least. Okay? So they don't ask how was the patient yesterday. They ask how was that patient 1 month ago. So they make tests and they study what they call frailty. And it's a concept that us INRs should be more close to it because it's really a nice concept. It defines how we work in the last years of our lives. So we become frail. That means that we are more prone to becoming ill, becoming dependent. So this frailty, they have different scores. And the last stage of frailty is dependence. So we know that we can improve any frailty level, but the last one. So we need to move the patient out of the high frailty scores to avoid them to become dependent. So that's how we work. So we work in those patients to avoid them becoming dependent. And the nice part is that we are starting to see the clinical impact of treating MMA. And I think this is key. So we need to start to be close to this concept. So, for stroke, we learn ranking score.
Right.
So for CSDH, we need to understand this frailty score. And we've been studying these frailty scores, and we show that patients that we embolize, we get them to the previous state. So we move them away from dependence. Oh. And I think that's how we need to define the next big trial in CSDH. So patients without surgery are not candidates to surgery, and the main variable should be dependence at 3 months or at 6 months. So this is it, and it's a nice idea. So they study these patients, and if they believe they are not dependent, then we treat them. So we do the MMA embolization during that admission, and after that, they take care of the whole patient. They look for every variable that may appear during the admission, and they discharge the patient. So we try to do it really fast because, don't forget, old patients, polymedicated, polypathological, means they are going to get confused in the hospital. So the fastest we work, the better for the patient result.
Right. But tell me, so 2 questions related to what you just said. Your neurosurgery patients, the patients who primarily went to neurosurgery, you said they would give you a call if they thought that there was a chance for recurrence. So you mean they decide if it's going to be recurrent, or they wait for a second episode and then give you a call?
So we have the 2 options. If it is recurrent, they for sure call us. But if the patient is in high risk of recurrence, meaning, for example, double antiaggregation, anticoagulated patients, they call us. Yeah.
They give you.
Oh, yes.
Right. And
it's part of our protocol.
Right. Suppose the patient primarily has membranes in
Yes.
the SDH, and initially neurosurgery has operated. So they give you a call straight up.
Yes,
and
but not based on the CT, based on what they see in the
when
OR.
they do
Yes.
the OR. Okay.
So normally we get the call from the neurosurgeon who has operated. So they call us and they say, I've seen lots of membranes. So it's not based on the CT itself. It's more based on their own experience that they call us. Yes.
Okay, which is interesting, which means that they have caught on to this change and they are, which is what I was getting at, which means it's a change in mindset that at least in your hospital, neurosurgeons and geriatricians are working very closely with you to kind of make sure there's no recurrence in this subset. Right?
Yes, we started with geriatric doctors, but yes, neurosurgeons right now they are on board and they started to believe in this technique long time ago. Yeah, so right now we are in a really nice position.
And the second question was that the frailty score, like the MRS, like our Rankin scores, do they have any numbers to it? Because it's the first time I'm hearing of a frailty score.
No, it's like levels.
Okay.
So it's a first level, I can't remember the name, but the second is moderate, and then high frailty or something like that. It's like 3 or 4 levels.
Okay.
Yes,
but if a patient was dependent, they don't do it.
That's it. If the patient is dependent, there is no way to moving it out of that situation.
All right.
Yeah, so the lowest score of frailty, if you think about, leaving the cSDH by itself, means that the patient is going to be in bed for 1 month or 1.5 months. So it will be dependent because no one's going to be able to move that patient away from the bed after that. So that's the idea, yeah.
But, very interesting. Why I'm going to prolong this point is that because we haven't seen that mindset shift in many countries. So before we move on to the actual techniques and the how you do it part, I want to know, how did your neurosurgical community or geriatrician community, how did they adopt this change, which is not seen, in many countries in the rest of the world?
To be prone to cSDH.
Yeah.
Okay, so the thing is that if you focus only on the patients without patient non-candidate to surgery, then embolization is the best option for them.
No, we know that.
Yeah.
But
so the thing is that we work showing them that it works. And my recommendation is start doing a trial or a registry or call it
that's true.
the way that you prefer. That's the best way to prove to your people that your technique is working, because they will feel that it's under an investigation, frame that will allow us to be much more confident of the results that we are getting.
Which was very impressive because, now we have like the MAGIC MT and STEM and Embolize and CHESS, and there's a host of studies which are positively inclined towards MMA embolization and reducing recurrence. But your hospital, neurosurgery and geriatrics, adopted this prior to that, which is very nice, creditable.
Yes.
So, but what do you like, now coming to the embolization part, what is your standard technique in MMA embolization?
Okay, so we used MMA to train our radial capabilities of treating any disease. So that's why we started doing radial. You don't need that many catheters, that many guiding catheters. So normally we use a short sheath, Terumo sleeve. It's a really nice short sheath because the wall is really thin. So with a 5F hole in the artery, you are able to get up to 6F diagnostic catheters. So that's what we do. We use a Penumbra Select 5F That's a really nice catheter because it has a seam-to curve.
Shape in it.
And it allows us to go really far because it's really long. It's 130, I think.
Yeah.
So we place this catheter into the internal maxillary artery. And from there, we go with our microcatheter.
Right.
Which catheter? That's another discussion. So we started with Marathon. We like it very much. It navigates really distal. It's really smooth. It has almost everything. But the problem is that through Marathon, you can only place two kind of coils at the barricade and the Caneca. We don't have a barricade in my hospital, but we have Caneca. The thing is that they're a little bit expensive. So that's why we moved to Headway Duo. That allows you to put DMSO, allows you to put almost every coil. You can put Optima, Target, almost every coil. I will tell you why we did the change. So, of course, it navigates really distal. You can put squid, and it's really strange that it's gonna get stuck in squid. So it has almost everything that microcatheter.
So you use the 156 Headway Duo or the 167?
167.
So you're using 167. That's got a single marker.
Yep.
That's got a single marker. So when you so how you start with your microangiogram of the MMA?
So we do a microangiogram just from the intracranial segment of the MMA to understand a little bit better of the anatomy, to see if there is any kind of dangerous anastomosis or variant or anything like that. And then normally after that angiogram, we will go to the frontal branch. Okay? And then the technique is we are changing almost in every patient, I would say. So we started doing independent embolizations of each branch. So frontal, parietal, of each side. Right now, what we are doing is trying to get a good embolization of the frontal branch. Then maybe we will try to remove the headway or the Marathon, push it again. Once you have already closed the frontal branch, it will go to the parietal, and try to get a embolization of the two branches with the squid, but only wasting one microcatheter. That's what we are trying right now. If we can't do that, then we will remove the headway, go again with another headway, go really distal into the parietal branch, and try to squid it again.
So suppose you in the frontal branch and you finish this embolization, then you flush it with DMSO to get rid of the squid, and then no, we don't. So you just pull it back and
pull it back and push it. Yeah,
and
you can do that maneuver more easily with headway than with Marathon.
Yeah, headway duo is more. Yeah, it's much.
So
I agree.
That's another way of changing. So why we start with frontal? Because frontal normally is the more elongated branch, and it's more complex. So we've seen that lots of times that frontal branch has this just after the origin, 1 centimeter or something like that after the origin. It has this kind of a zigzag morphology, making it really difficult to go past that zigzag. So we try to do that with really low profile guide wires like Hybrid 7 or Asahi 8. But in a really high number of patients, we end up rupturing the MMA. So in those patients, what we do is that we place coils. Okay, so if you are not able to go through that zigzag, then you will place coils into the origin of the frontal branch, and that's why we started to use headway, because it will allow us to use every coil. So we block it from the origin, and then with the same microcatheter, we'll pull it back. With guide wire, we navigated the parietal branch. So from the distal parietal branch, we start injecting squid 12. Once we have closed the origin of the frontal branch, then that squid tends to go through anastomotic channels to the other branch. So we learned this from Fede Vallenilla, who's in 12 de Octubre. It's a good friend of mine. And he told me that he was doing this, and it's a really nice way of working.
Right. But do you really think, but it's not standard practice for you to coil the MMA after your EVO, right?
No.
So it's only in these cases
only in these cases where you have this kind of elongated frontal artery, or maybe a rupture frontal because of the catheterism or something like that. If not, we will microcatheter each branch and try to embolize it with. We normally use squid 12 because it's the more diluted EVO material that we have.
All right. And also, do you think that the premixed tantalum of squid scores over, say, an onyx or something, because the shaking precipitation might be a little different?
I also think so, yeah. So it's a combination between those two things that allow you to get, but I think that's, of course, personal point of view, not science behind this, but it's the feeling that we have, it's much better, yeah. And don't forget that we are not treating fistulas or AVMs in these cases. So you are not putting squid against a high flow fistula or a high flow AVM. You are pushing that material, that liquid embolic, into a capillary bed.
True.
So the pressures are much different than what we are used to with these materials.
True. What is your opinion about the use of glue or particles?
So with particles, we started doing so before treating patients, we do flow models. We did, I can't remember, we did them with, thanks to Hajid, she brought some flow models and we were working on them, like 5, 6, 7, I don't know, it was lots of flow models, trying to understand a little bit better the materials that we were using. So we compare squid and particles, okay? In our case was microspheres. Because those are the ones that we have in our lab. So we see...
What size?
We try them with the red ones. I think the red ones are quite big.
The red ones are the bigger ones.
I think so. I think so.
I think the one, the
yellow ones are 300? No? That's the thing that I know.
So, different companies have different color codes. But generally 50, 150 are the blue ones, and 150, 300 are the green ones. And but every company has a different.
So we started with that. Okay. And we did some runs in the angio lab and compare what we see in the angio lab with what we get in the flow model. And then if you were using particles, problem was that you get really nice picture in the angio lab because you see the contrast. And it seems that it's fulfilling the whole arterial anastomotic channels and everything. But what you see in the flow model was that you have much less embolization than you think.
So you mean to say that the penetration into the dural blush area, the capillary network was less.
Less. Yeah, less. While what you see with squid was pretty much what you get in the flow model.
So do you reduce your squid 12, you dilute it even further? Because in a few cases I've like diluted it even further
with DMSO, no?
Yeah, with the DMSO.
No, because I am really afraid of DMSO. I think it's one of the more toxic venoms that we so but I understand your point of view, because if we love squid 12, why don't we create squid 6 or onyx 6 or
because some arteries are really thin and just to improve the penetration in a few select cases. But of course squid 12 works really good.
And the glue so we rule out particles because of that, not because of their final result, okay? It's because we were really afraid with safetiness. Okay, so safety was one of main reasons for us. So we
because you can't see it as well.
Don't forget that we started in 2019, so there were no publications. So we were really afraid of complications, and we believe at the beginning that squid was easier to see, meaning that if it was going to some problematic branch, we will stop. So that's why we did this approach. That's why we rule out particles or ice spheres, and then glue. So we've tried it. Glue sometimes it works. I don't think that you can get that good injections because you have to be faster. Okay. We were discussing a couple of days ago about the really diluted glue that the probabilities of getting the microcatheter stuck are smaller than with standard glue. But we are glue users for dural fistulas, for spine dural fistulas. But in this case, we were afraid of catheter getting stuck. So that's why we moved to squid directly. And as we told before, we work with tenders in my hospitals. So back in those days, we were used to buying like 300 vials of EVO material due to AVMs. But back in those days also we stop or we decrease the number of ABMs that we were treating. So we have this big stock of material. So it was really easy to move from one pathology to the other.
Okay. What about coils?
What about coils? So right now we only use coils in these cases that I told you that we have a complication or that we want to close an artery to get a better collateral flow.
But what about just coils?
Just putting a coil? I don't know. I think that putting a coil by itself is not going to solve the problem. But if you tell me that you are going to put a coil and then through the coil or like kind of jailing a microcatheter, putting coils in parallel and then put some drug, that's different. That's different because the coil, it will allow the drug to stay still in the membranes and maybe that will work. But a simple coil, we've done 2-3 cases with coiling, with proximal coiling because we were not able to navigate further. And in those patients, it went well, I would tell you. But I don't think it's gonna be the solution for this pathology because you are not getting to the distal bed. You know, you are, I don't know. We'll see.
We'll see. Let the trials come out and we'll know.
That's it. Because maybe in a couple of years I will tell you this is the best solution. We've seen the trials. We've studied it. But yeah.
Right. Because now, you know, there's a trial which is even injecting tranexamic acid and seeing. There's a trial in which there is
VEGF.
Yeah, there's a VEGF inhibitor. Bevacizumab is being injected. I've asked. So we will see. There is a lot of work being done in this field. But what about, say, when you've done one side, do you go to the opposite side even if there's no SDH on that side?
So we started doing only ipsilateral.
Okay.
If it was bilateral, we will go bilateral. Even if it was really small, the bilateral, but okay, we decided to go bilateral. So what we learned is that we were having a little bit of recurrence. Not that much, maybe 4% of the cases, but you know, that's more than what we normally want. So after that, we moved our protocol. And right now we are embolizing the ipsilateral side, and then we are starting from the internal maxillary artery of the contralateral side, how well MMA is crossing the midline. So if we see that there is collateral flow crossing the midline, then we will go for bilateral embolization.
Okay, so only if you see that, otherwise you will not.
That's it. Only if we see that from the internal maxillary artery. Because if you go into the MMA and push it with contrast, then maybe you are opening those collateral flows, but it's not real. But if you injected it from internal maxillary, then it's really far away. So if you see those collateral flows, means that they are already open by themselves. So there is a higher risk of recurrence, we believe.
Right. And in your series so far, what is your recurrence rate of MMA embolization plus surgery versus only surgery? Have you reduced your recurrence rates?
So we have not made that comparison because in this registry that we did, surgery patients were not included.
Okay.
So we only study the embolization itself, and we've seen that the recurrence rate is really low. Yeah.
So if we compare it to say literature, historical controls,
yes, that
you feel that in your series you have a reduction significantly.
Yeah. Maybe it's not 20-4, it's maybe 15 to 4-6, but there is a clear reduction. And moreover, the nice part is that there is also a complete resolve in the patients without surgery at 6 months.
Right.
So we started to see that first month symptoms improve. And I'm talking about the geriatric patients. Symptoms improve even though the cSDH is pretty much the same size. At 3 months, it's less than half the size. And at 6 months, normally, we have a complete resolution of 95% of the cases.
Oh, that's pretty good. So 95% is good. And what is your anesthesia protocol? You do it under local anesthesia?
So we started with local anesthesia. And it was a funny story because So we started with this local anesthesia because, they get a blowhole with local anesthesia. So it was really aggressive to go with general anesthesia. Again, aged, polymedicated,
Right.
polypatholic patients. So with the first 7 cases, it was the anesthesiologist herself who talked to us, and she said, they are suffering a lot of pain. This is really painful.
Yeah.
So we can put them under general anesthesia with a larynx mask and it will work, don't worry. That's why we started doing general anesthesia. So right now, for us, it's a general anesthesia patient 90% of the times, unless general anesthesia is completely ruled out. So it's funny because in my institution, we don't do general anesthesia for stroke, but we do it for cSDH.
Oh, all right.
So this is how strange we work. But it's because based on our results.
Right.
So we try to base everything in our results and personal results in the institution. And with this way of working, it's been working, and patients are doing really well. And we've had no kind of anesthetic complications. We have really good anesthesiologists, and they are used because our population is really old. So they are used to old people.
So do you like injecting a little bit of lignocaine to reduce the spasm?
Yeah. So we started with that in lidocaine and verapamil injection prior to the MSO. So we started with a total amount of 5 milligrams of lidocaine. It was not useful. Then we moved it to 10 milligrams. Same idea. So then I started to talk with lots of people, and they told me, no, you have to put 20 or more. So then we started using 20 milligrams, and then some anesthetic effect is produced. So patients that we cannot use general anesthesia, we use this protocol of 20 milligrams of lidocaine directly injected in the artery prior to embolization.
Right.
But we still get that pain in the patient, that movement. So, yeah.
So you're using 20 ml of 1% lidocaine?
No, not 20 ml. It's
20 milligrams?
Yeah.
20 milligrams.
You have to calculate.
Yeah.
I think it's 2 milliliters.
2 ml of?
Yes, I think it's 2 ml.
Okay.
I think it's 2 or 5. Yeah, it's something like that. But you have to make the calculation because each one of us has a different
I don't know what you all have
lidocaine
out there,
concentration.
We commonly get 1%. So
Yeah,
I
but
don't know.
normally we have, I think it's 2% for us.
Okay. So we take like 1 ml of lidocaine and dilute it with 3 ml. No, with nimodipine.
Nimodipine. Okay.
Nimodipine. And then after that, inject very slowly and tell anesthesia too. And then after that, we.
And you go to deep sedation?
Yeah, we do it with either dexmed, conscious sedation, or sometimes under GF the patient is really bad. But that's. And what is your follow-up protocol like? Like when do you image and when do you call the patients back?
So into the study protocol, it was 1 month, 3 months, and 6 months control.
All right.
Okay. So, and at those stages, we did a CT and a clinical evaluation. Right now, I will tell you that most important visit is 3 months.
Right.
Because at 3 months, you will see half or more completely resolved. You will see the ones that are decreasing in size, and those ones we can have a CT at 6 months to confirm the complete resolution. But you will be able to detect the ones that have increased in size, or that at least have the same size, and those are the high risk of recurrence.
So do you take that subset for a redo embolization?
Yeah, we tried to at least to study the anatomy to see if something has changed. Yeah, but if we have already done a bilateral complete embolization, then there is we don't know why we have that
and
recurrence.
Let's assume that you have had a situation where you have a ophthalmic which is coming from the MMA. So what is your how do you go ahead?
So we've had 2 situations. That is the ophthalmic arising from the MMA or the MMA arising from the ophthalmic.
Right.
So we started, I think, first 2 or 3 years, we did nothing with those patients. So those were failed patients because, we were not sure that we were doing the correct treatment for those patients. We believe in the technique, but it was inside a study. So putting those patients was a little bit risky. So that's why we did nothing with them. After the results, or after seeing that we were providing a good and safe technique for the patients, we become more aggressive. More aggressive meaning that, for example, an MMA arising from the ophthalmic, what we do is that we try to get to the MMA and we place coils. Okay? Why? Because getting really distal, putting squid, and then
chance of embolization.
You have a chance of moving a little bit of squid into the ophthalmic, and that's dramatic. So we believe that the safest technique is to place some coils in there, and that's what we do. And if the ophthalmic arises from the MMA, we have to be sure that squid does not get to the ophthalmic. But with squid, it's really easy because you see the product. So normally we tend to go really distal, and from that distal part we start. And of course, if we have this situation, we are not really prone to reflux. So we stop the moment we see more reflux than what we want.
And what coils do you use?
Through Headway, you can use the Optima, the small ones, or the Target. And through the Marathon, we use the Canica.
So Canica also less than 5 millimeters.
Yes, the small ones, less than 4, I think it is.
Yeah.
Those are the only ones that you can use through Marathon. And the nice thing with the Canica, I don't know if you know that.
We had it many years ago. It's left India.
Okay, so you can place them really safely with 1 mark microcatheters because of the release technique.
So we had that, but they were more expensive, and I think they're no longer in India.
Yeah, no, it's crazy expensive. That's the problem for us. Yeah, it's twice the price of a standard coil in our institution. So that's why we are trying to use less. Yes.
Right. So because some of the arteries, see, there's also, I don't know if you're aware of this, but there's a regional difference in our sizes. So the arterial sizes are also different. So which is why 1 mm, 1.5 mm, 2 mm coils are the standard coils that we have out here. But we need these really long coils, which are good, which are designed for this, which will help. So I don't know if you get them.
No, not yet. But you know that we need to use what I call the Japanese coil. Japanese people, they are crazy about low diameter, long coils. I don't know if you've talked with them in meetings, but they love these like 1.58.
Yeah,
it's something that we don't have that in mind, but when you talk to them, it's like, it's the best coil. But for coiling aneurysms, not for.
Which company comes out with 1.58?
I think that they are working on that. Every company is working on this kind of measure. So ask for them because ask for the Japanese portfolio, and then some of them they will surprise you. Sorry,
that's
maybe not 1.58, but 1.56 or something like that. Yeah, they love this.
Yeah, it makes
lens.
sense, In sometimes in aneurysm, you want the really small ones to pack the last one.
Once you inflate the balloon, and then it's like, okay, it makes a lot of sense. Yeah, it's once you talk with them, it's like, yes, it's not that crazy. You have to put a balloon or stent or whatever because it's not gonna be easy to place
I
that
think they're designing coils for MMA embolization too.
Yes, also they are based into that. They are working in designing coils for treating those MMAs. Yes, like progressive increase in diameter or progressive decrease in diameter.
Right.
Yes. Right. So we will have those products in nearby future, but I think those ones will be more useful to create pressure cookers in AVMs than treating the pathology or the MMA itself.
That's really nice if you can. You're right. What about your redos? In case there is a recurrence, and we have already used EVO to embolize it. So after you do your angiographies, do you go via the collaterals? How do you deal with these recurrence situations?
So, if the cases that we've had, normally we do the diagnostic angiogram of the ipsilateral side, and everything's closed normally. What you have get is contralateral flow. So we go to the contralateral side and we make a complete embolization. But we have never, for example, went through a anterior meningeal or posterior meningeal. Maybe that's the thing to do if you have done a bilateral embolization, it was complete, and you have a recurrence, that maybe posterior meningeal or anterior meningeal are given too much flow to those vessels. But I think that each technique has its own limits, and maybe that's the limit for this one. So I don't know if going into a posterior meningeal is maybe too aggressive to treat these patients.
Right. And now the cSDH, what is important is also to learn how to spread the information about these new developments which can benefit our population. So how do you think we should go ahead with improving this?
Yeah, so first thing is that there is a paper, I don't remember the main writer, but it's a nice paper talking about how much time does it take to generalize a big clinical result. And in that paper, they concluded it takes 20 years.
Oh.
Okay, so first of all, we are not that bad.
Right.
Because that's what I try to tell everyone. So we've been, trying to expand stroke for 10 years,
right.
and we are not that bad. Yeah. So cSDH has just started.
Right.
So most important part is that we need to get in contact to the referring doctors. So half of the population is into neurosurgery departments. So we need to go to neurosurgeon meetings, to talk with them, to explain the results that we have and everything like that. And of course, we cannot forget internal medicine doctors, with general practitioners, geriatric doctors, that they will get these kind of patients. And don't forget that for those patients, this is the only treatment available.
True.
So we need to be there. And that's why last year we went to the European Geriatric Society meeting, and we start talking about this concept, and they love it, and they are really prone to work with us. So my first advice is get in contact with those geriatric doctors, because they will love to hear that you have an option for these patients.
Let's say that you have patients who have a first-time traumatic SDH. What are your thoughts on the use of MMA embolization for traumatic SDH?
So I don't think there is much space for that, because if we believe in physiopathology, the acute cases, normally it's because of a high trauma or whatever, or a fistula maybe. So MMA embolization in a fistula, it has its effect, but if it's traumatic, maybe it's related to those bridging veins that rupture. So we are not going to get those membranes in these kind of patients, meaning that once the acute situation is resolved, there is no need to do nothing else than follow up. Even if the patient is more prone to recurrence,
I agree.
I think that we need to prove that there are membranes. So maybe if 1 month after that acute...
But what if the traumatic brain injury patient is on anticoagulation?
Yeah, but if there are no meninges, if there are no membranes, meninges there are always. If there are no membranes, there is no, MMA embolization, it's nonsense.
It will not make sense.
The thing is that after that trauma, cSDH may be developed, but that's a complication of the trauma, not related with the original.
Because
acute.
there are some operators now who are taking the subset of traumatic SDHs who are getting anticoagulated, and because they can't stop the anticoagulation because of heart valves or other reasons, they're doing a prophylactic MMA embolization, and apparently it works. The same with liver transplant. If you have a liver transplant unit and the INRs are deranged and they're not clotting, and they have an SDH, that's another subset of patients that they're prophylactically taking up for embolization. So
I don't know, maybe, but we don't have enough data to say it. So it's interesting,
It's interesting.
Of course, you will reduce the recurrence rate, but if it's acute and it's traumatic,
apparently
the recurrence is...
it's not for the recurrence part. It's apparently it reduces the pressure because the duras are getting vascularized. So the capillary pressures, which are supplying the meninges, that reduces. So when they are leaking, because of anticoagulation or whatever, that's kind of reduces the effect.
Okay.
So it helps them bridge or tide over that part.
But the thing is that they will operate all the acute cases, no?
Sorry?
The acute cases will be with a blood hole or whatever. They will.
No. That's assuming that that
they don't. Okay. So that's different. Yeah. Of course, in those patients, maybe there is some sense into doing this. Yeah,
but that also opens up, some
Oh,
windows of other indications. I don't know.
Of course, and also the headaches.
Yeah,
They're starting to treat headaches with MMA.
Yeah.
Not embolization, but drug administration or whatever. Yeah, that would be great for the patients if we can give them another option to treat their headaches. Yes, that would be great.
That's. Migraine treatment, or what we term migraine, is changing every day.
Yes, it's completely changing. So it's and really complex to analyze.
That's nice. If you have to kind of mobilize thought process behind SDH, now we have some trials which are already published, like Magic MT, the China trial, or we have the Onyx trial which just came out, or now I think there's a trial, like chess, which is on, I think, particles contour based, a US based trial. So the multiple trials which are coming out. Do you think that in the near future we will be seeing some change in our guidelines?
I think that to change guidelines, we need clinical variables. That all the trials that we've already presented, they use kind of radiological or combined variables and variables, and that's the main problem that we are facing, because there are some neurosurgeons that they don't trust those papers because they say that the reduction is not that high, that it's only based on some patients, not all of them. So I expect that the guidelines will change, mainly because what all the papers show is that with embolization, surgery complications decrease.
Yes, true.
And also recurrence. So it's kind of the two advantages in one treatment. So they will change. I was expecting to change after these 3 big trials, but I don't think they will change in the nearby future. So we will need more publications, and they will eventually change, and maybe in a couple of years we will have these new guidelines suggesting to treat all of the patients non-candidate to surgery and the high recurrence rate patients after surgery.
True. Thanks a lot, Manu. It was a pleasure to talk to you about cSDH, its indications, your techniques, and how to increase it, because it's going to benefit a lot of patients. It's going to benefit neurosurgeons, because it's a mess to go into recurrent SDHs and try and evacuate that, and it's not fun for them too. So, and it, like it dries up so much after your embolization. Patients almost have clean brains at the end of it. So, thanks a lot. It was absolutely a privilege to meet you and having you.
It was my honor. Thank you, Rajeev. Thank you very much.